Good evening, everyone. How are you all? Great. So tonight we are going to finish psychiatry. Have you guys started reading psychiatry? Great. Okay, so let's continue our session. And at the end, if you have any questions, you can always ask. Okay? So today we are going to start from gender dysphoric disorder. So gender dysphoric disorder, it's from Kaplan step to psychi. It is also known as gender identity dysphoria. So what is this gender dysphoria? It's a disorder characterized by persistent discomfort and sense of inappropriateness regarding the patient's assigned sex. So gender dysphoria means that someone, let's say a male, who feels that his assigned sex is inappropriate, that means he should be a female. So if someone has got this kind of persistent sense of inappropriateness regarding their assigned sex, then that becomes a case of gender dysphoria. Now, there are a few terms that we use. So let's have a look. So Mark's manual, so if you go into this guideline, you will get an idea about few of these terms that we use. So let's move. Let's see if we can open this up. Okay, it's not in here anymore. So that's fine. I can discuss without that. So first of all, there are a few terms that you need to remember. One is gender dysphoric disorder, which is like the broader term. The broad term for anyone who feels their assigned sex is inappropriate is what we call as gender dysphoria or gender identity dysphoria. Under gender dysphoria, there are a few other things. One is transsexualism. Another is transvestism. So there is a difference between transvest and transsexual. So transvest means that there are some patients who get sexual arousal if they wear clothing of opposite sex. So that's called transvestism, where they don't feel that they have inappropriate sex. That means transvestism patient don't want to change their sex, but they get sexual arousal after wearing opposite gender clothings. Whereas transsexualism is a patient who has severe form of gender dysphoria, where they feel that definitely they have an inappropriate gender, and at the end, they change their sex. So when they want to change their sex, that becomes transsexualism. Okay? So we say that gender dysphoria, they have this inappropriate feeling that yes, their assigned sex is inappropriate, but they don't want to, that means it's not severe enough that they want to change their sex. But when someone changes their sex, the term that we use is called transsexualism. Okay, so there is three terms that you need to remember. One is gender dysphoria, which means that they have inappropriate feeling, but they are still not changing their sex. Transsexualism, which is the extreme form where they change their sex. And transvestism, they don't want to change their sex, but they get sexual arousal. Okay? Okay, I'll just see that who is this Redmi 10A who is always asking about audio problem. Let me just sort it out. Okay, so what do you think this patient has got? So I can see you guys already like answering the questions. 19-year-old woman is hospitalized for dehydration caused by severe laxative-induced diarrhea. She is depressed about the recent breakup of a romantic relationship. She admits that she uses laxatives because she has been binge eating frequently, worried about gaining weight. Although her BMI is 16, she believes she is overweight. So this is what we call as anorexia nervosa, where their BMI is quite low. We'll discuss about eating disorder today, which is a very important topic. But let's first finish defense mechanism and then we will come to the eating disorder. Okay? So defense mechanism comes in exam and it is quite difficult sometimes if you don't understand what these defense mechanisms are. So we are going to discuss all of this one by one. So this is from Kaplan step to psychi, but we are going to discuss from med bullets. Okay? So a human being has mature and immature defense mechanism. Immature defense mechanisms are more common than mature. So immature means which you can't control. And it's like a primitive defense mechanism every human being possesses. So lots of immature defense mechanisms are there. First of all, acting out. What is acting out? Acting out means that if a person uses action to express something unacceptable for them. Let's say someone just lost their job and then that person suddenly started to break things at the office. So what he's doing that because he's been fired, he is now using action to express this unacceptable feeling. Okay, so when someone uses action to express something unexpected, something unacceptable, that's what we call as acting out. Now, what is the opposite of acting out? Opposite of acting out is what we call as passive aggression. Passive aggression is like you are angry, but you are not doing anything like acting out. So you are expressing your angry feeling in a non-confrontational way, which means that let's say you are angry with your best friend, but you are not saying anything to him or her, but for the next few weeks, you did not talk to her, you did not receive the phone call, you just totally avoided her. So how did you express your angry feeling? So you expressed your angry feeling in a non-confrontational way. But if you just punched her, that would be acting out. Okay, so that's acting out and then passive aggression. Yeah, silent treatment, that's right. Okay, the next one, dissociation. We already know what is dissociation. That's like dissociative amnesia. All of these are part of dissociation, which is what we call as temporary drastic change in behavior. Denial. Denial is important, comes in exam. So if someone avoid awareness of some painful reality. So let's say that someone just right now you have told a patient that you have bone cancer. For the next few days, the wife is asking the patient that what happened? What did the doctor say about the imaging that you had on your back? Patient says nothing. I'm totally fine. I don't have any problem. Doctor said I'm totally good. So this initial refusing to believe something really stressful for someone is what we call as denial. Okay, so avoidance of some painful reality is what we call as denial. Okay. Dissociation, remember Dr. Sana, the one that we discussed in our last session, dissociative amnesia, dissociative identity disorder, those are the same thing. So it's not anything new today. And we discussed about dissociative identity disorder, it's the same thing. And in a sense, it is like a temporary change in behavior. Like dissociative amnesia means someone just like can't remember their past memories. That's dissociative amnesia. So we discussed this, so let's not go into the previous class today. Displacement. So displacement means that if someone take out their feelings on a neutral third party. So let's say a patient or a person had a very bad fight with his wife. So, and then because he couldn't say anything to his wife, he started yelling at his dog. So dog did not do anything. So he's that neutral third party who is getting all the anger. So when someone take their feelings out on a neutral third party, that's what we call as displacement. Fantasy fixation is not important. Identification. Identification means imitating behavior of a more powerful person. So if someone imitates behavior of a more powerful person, that becomes identification. Like the example that they have given here, abused child becomes abusive later in their life. So a child who was a victim of violence during childhood, later on when he became parent, he also became abusive. So imitating behavior, either it can be good behavior or bad behavior of a more powerful person, that's what we call as identification. Isolation of affect. What is isolation of affect? It's separation of emotion from events or ideas. So isolation of affect means that when there is lack of emotion from a particular event or ideas. Like if your patient is describing a murder in every graphic detail possible without any emotional response, that becomes isolation of affect. Like let's say someone lost his friend and he was died of a car accident, and the friend who has survived is describing each and every detail of how the friend is dead now or how the car accident happened. That is what we call as isolation of affect. So separation of emotion from some event, ideas. Okay. We discussed passive aggression. What is projection? Important for exam. Projection means attributing unacceptable internal feelings to an external source. So this one gets confusing with the displacement. So when someone attribute something really unacceptable, like they are doing something wrong, but they are actually saying that, no, you are doing it. So let's say a husband who is cheating with his wife suddenly started claiming that the wife is actually cheating. Okay, so this is actually what we call as projection. So something that your patient is doing and he can't accept it actually. So that's why he's projecting that unacceptable feeling to someone who is not doing anything. Now, how it is different from displacement is that in displacement, there will be three persons. And let's say that there are two persons who is fighting, or initially there was two person who was actually the main first and second person who is doing all the fighting and problem, and the third person who doesn't have any idea what's going on get all the anger. So that's displacement. But projection means that it has to be like something that you are, like something a person is struggling with, like which is unacceptable, and they will say that, like let's say someone murdered someone, or a person murdered someone, and then because there is an unacceptable feeling, he is now projecting that, no, I haven't done anything, someone else has done it, or my friend has done it. So when you project some unacceptable feeling to someone, that becomes projection. Okay, in displacement, you don't project anything. You don't say that like 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 you have done something wrong, and you don't project that to someone else. You just yell or you just become angry. But in projection, your unacceptable feeling will be projected on someone else. Okay. After that, we have got rationalization. Rationalization means making excuses to avoid the real reason or to avoid self-blame. So someone who failed an exam and is claiming that grades are not very important. So when someone make excuse to avoid self-blame, that's called rationalization. Okay. Reaction formation. Reaction formation is replacing an unwanted idea. Now this is important and it gets confusing in the exam. Replacing an unwanted idea or feeling with its exactly opposite. So what does it mean? That when a patient replaces an unwanted feeling with its exact opposite feeling, like a patient who, like let's say a patient who is a thief or who used to be a thief suddenly became a priest. Okay. Or a patient who has hypersexual thoughts becomes a nun. So when a patient replaces something unacceptable or unwanted to exactly its opposite, that becomes reaction formation. Then regression. Regression means that especially it is important for children. So children gradually they develop milestone. So children, let's say a 4-year or 3-year-old, they might like they will not be toilet trained, but by the time they're 6 or 7, they should be toilet trained. So a toilet trained child suddenly started to wet the bed, that becomes regression. Regression means back to more childlike behavior. So suddenly a toilet trained child started to wet the bed, that's regression. And many times regression happens when a child is under a lot of stress. What is repression? Repression means involuntary withholding of bad thoughts from consciousness. This is also important. So let's say that someone who just had a sexual abuse or a rape, and when police asked what happened and asked to describe what exactly happened, the patient did not, or patient was not able to recollect the event. Or patients say that I can't remember what happened. So that means now this is not a voluntary withholding. It's involuntary. Sometimes our brain works in this way so that we can survive. Okay, so involuntary withholding of bad thoughts from consciousness is what we call as repression. Splitting. We discussed about splitting, which is a finding in borderline personality disorder. So splitting means if a patient believes that people are either all good or all bad. Like a patient says that a resident is mean in this hospital, but medical student is very warm and caring. So he's saying, or this patient is saying, all the residents in the hospital are bad, all the medical students are good. So that's called splitting. Okay. So these are the main important things that comes in exam. There are some mature defense mechanisms like altruism, where patient like alleviate their guilt with charity and generosity. Not important. Sublimation, suppression. Suppression is important. Repression means involuntary withholding of bad thought. Suppression means voluntary withholding of some bad thought from consciousness. So if you don't want to say something that you are stressed about and you say, no, I can't remember. So when you do it voluntarily, that's suppression. Okay. So that's all that usually comes in exam. So to recapitulate everything, acting out means using action to express unacceptable feeling. Denial, when you avoid awareness of some painful reality, that means you just say nothing happened. Displacement, when you take out your feelings on a neutral third party. Isolation of affect means when you separate emotion from an event, like describing the murder. Passive aggression, when you express your angry feeling in a non-confrontational way. Projection, when you attribute something unacceptable that you are doing on another person. Rationalization, making excuses to avoid self-blame. Reaction formation, replacing an unwanted idea or a feeling with its exact opposite. Regression, going back to previous childlike behavior. Repression, involuntary withhold of some bad thought. Splitting, either good or bad. Okay. So that's all the defense mechanism that human being uses for different purposes. Any question with this? Let's solve this question, see if you guys have understood what we discussed. A nurse working in a hospice has been ignoring an elderly female patient who has terminal cancer. When asked why she has been ignoring, the nurse replied she wants to be left alone. Which of the following defense mechanism best explain her response? What do you think? Rationalization, isolation of affect, intellectualization, projection, denial. She did not deny it, right? Is she projecting something? No. This is called rationalization. Actually, the nurse is ignoring, but she is rationalizing by saying that she wants to be left alone. Okay? Good. And altruism means that if someone alleviates their guilt by donating something. Okay, that's all about defense mechanism. The next topic that we are going to discuss is dementia and delirium. Very boring topic, so don't sleep. Now, dementia and delirium. First of all, dementia and delirium means that dementia is very chronic and insidious onset, whereas delirium is very acute. So if someone like an elderly patient coming to you with a sudden confusion and also like acting very strange, you can diagnose her as delirium. So acute confusional state is what we call as delirium. And if someone having chronic forgetfulness, behavioral disturbance, that becomes dementia. So main part of diagnosing dementia is it's chronic, and main symptom is loss of memory, whereas delirium is acute or sudden confusion. Now, to check the dementia or loss of memory, we use this mini mental state examination or MMSE. So it is the best indicator of dementia, should always be evaluated by a formal memory testing. So lots of memory testing is available, but we normally follow the MMSE. The guideline of MMSE is the score is up to 30. So we say that if a patient gets 19 to 23, if there is score, that becomes mild dementia. 10 to 18 is moderate dementia, and less than 10, severe dementia. So if a patient has got less than 10 MMSE score, they usually don't retain any capacity to make any medical decision. But sometimes mild to moderate dementia patient, if they understand what we are saying, and if we are satisfied with that, then they will be able to make decision. Okay? So what we normally check in MMSE? MMSE, we check oral LC. So oral LC means orientation, registration, attention, recall, language, and construction. So these are the 6 things that we check in a patient who has dementia, and it's a part of MMSE assessment. Now, you don't need to know how we do it. Only thing is that orientation means that we check if the patient understand, like if they're oriented to time, place, and person. That means if they know where they are, what is the date today, that's orientation. A delirious patient will not be oriented. So loss of orientation suggests delirium. Registration, you ask the patient or you say few objects' name and you ask the patient to tell you those names. So you say that I'm going to tell you 3 names. Can you repeat it after me? So you'll say apple, coin, table. And patient needs to say apple, coin, table. Patient who has dementia, they have difficulty to retain this information. So dementia patient will not be able to say all the 3 objects at a time. At the time when registration is done, you also ask the patient to remember those 3 objects because you are going to ask it again. That becomes recall. So patient who has dementia, their recall is also affected. So that's what we get in dementia patient, loss of registration and loss of recall. Attention, you ask the patient to spell some word backward. So loss of attention can be found in delirious patient. And then language and construction. In language, you ask the patient to do few things, ask the patient to repeat a phrase, and lots of other things are there. And construction, you ask the patient to copy a diagram. So language construction can be impaired in both delirium and dementia, but this is very important to remember. Orientation and attention will be impaired in delirious patient, whereas registration and recall will be impaired in dementia patient. Apart from MMSE, sometimes we can also do this clock face drawing test. So this is a simple test which gives us an idea if a patient has got cognitive impairment, especially dementia. A dementia patient, they have difficulty to draw the clock. So sometimes we ask the patient to just to draw what is 10 past 4. So they have this problem to draw the clock face. Okay, so that can be found also in a patient who has got dementia. So what are the clinical features of early dementia? Okay, Dr. Shabab, how to check attention? It's not needed for you to know, but attention, we just ask the patient to spell some word backward. Like if you ask the patient, can you spell world backwards? So you ask the patient to spell world backwards. If a patient is having not much of attention, then they would not be able to do that. Do we score literacy level as well? No, we don't. And for illiterate patient, it is a different thing that we do. We can't do this one. So what are the clinical features of early dementia? Early dementia patients, mainly they will have poor recent memory, difficulty to retain new information, difficulty to remember names. They will have more and more personality change, okay? Inability to perform their daily routine activities. Now, patient with depression and dementia can be quite confusing to differentiate between these two. There is a term called pseudo-dementia, where a patient who suffers from major depression can have features of dementia. So it can be quite confusing in the exam that what they're talking about. Is it dementia or pseudo-dementia? So you need to know how to differentiate between these two. Okay? So a patient who has got dementia, the onset will be chronic insidious, whereas pseudo-dementia, who actually has major depression, their onset can be acute. Pseudo-dementia get worse in the morning because, as you know, depression can get worse in the morning, whereas dementia get worse in the evening or night. But the most important finding is insight. A dementia patient will not have any insight, whereas severe depression or pseudo-dementia patient will have insight. So this is the most important thing which can help you to differentiate between these two. Other than that, dementia patients' orientation can be poor. Then loss of memory, dementia patient, mainly their recent memory will be lost more than the remote memories. Whereas depression patient, they can have both recent and remote memory loss. Another thing which sometimes exam give you clue to diagnose pseudo-dementia or dementia is this: response to mistake. So when you do the MMSE, if a dementia patient will try their best to score higher in MMSE. So if they make any mistake, they will become agitated that why did they make the mistake? Whereas depression patient doesn't care. So whether they are doing mistake or not, they will not care about it, and they can even give up very easily. Okay? So this is how we differentiate between dementia and pseudo-dementia. So it's all written in here. You can go through that. So it comes in exam a lot, remember it. So what are the causes of dementia? So as the patient gets older, dementia risk is higher. So we say 1 in every 10 person over 65 can have dementia, which is a lot, right? And 1 in 5 over 80. So the most common cause of dementia is Alzheimer's disease. Then we have got dementia of frontotemporal, so frontotemporal dementia. Then Lewy body dementia, vascular dementia, alcohol-induced, and lots of others. But these 3 or 4 are important. So how how Alzheimer patient usually will present? Alzheimer patient, their main symptoms or their initial symptom will be forgetfulness or loss of memory. And then after loss of memory, they will have behavioral change, personality change, all of this. And in Alzheimer's, many times there will be a family history of Alzheimer positive. In frontotemporal dementia, you know that your frontal lobe mainly makes you who you are, right? So your personality depends on frontal lobe. So in frontotemporal dementia, patient's main presentation will be like their personality change. So early manifestations are personality change, behavioral disturbance, social dysfunction, and then memory loss will appear. How about Lewy body dementia? Lewy body dementia, it is characterized by 2 out of 3 symptoms. So if a patient has got visual hallucination, motor Parkinsonism, and then memory loss or fluctuation in their mental status. So first of all, Lewy body dementia is common in Parkinson patient. So you know that there are some abnormal gait in a Parkinson patient, right? Like a slow shuffling gait and all those different gait pattern. So patient who has got Parkinson motor disturbance, which means the gait disturbance, with that they have got memory loss and visual hallucination, then you can diagnose them as Lewy body dementia. Now all of this, Alzheimer, frontotemporal, Lewy body, these are little bit chronic onset. But one of the dementia can be quite acute, which is what we call as vascular dementia. Suddenly, patient started to get like loss of memory, can indicate underlying cerebrovascular event like a stroke. So sudden onset of dementia in a normal patient can be an indication that it is the stroke which is causing vascular dementia. Okay. So this is the main 4 cause of dementia, and you need to know how to differentiate between them. In here, they have given DSM-5 or 4 criteria to diagnose dementia. You can go through it. Dementia and Parkinson disease. So as I said, that Parkinson patient can develop a dementia, which is Lewy body dementia. There is a problem with this, that Lewy body dementia is extremely sensitive to typical antipsychotics. So what's the problem is, in Parkinson patient, if you need to give you normally need to give them levodopa or carbidopa, right? That's the usual treatment for Parkinson. And for dementia, there is no specific treatment that we do, but there are a few things which can be tried, especially if we think Alzheimer's, which we will discuss later on. But the problem becomes is that Parkinson patients suddenly developing hallucination, becoming psychotic, you need to give them antipsychotic, right? The problem is that patient who has Parkinson, they have loss of dopamine in their brain, right? That's the main pathophysiology of Parkinson. And what antipsychotic does is that it blocks the dopamine. So that's the problem actually. So if you've got a patient who has Parkinson and having psychotic feature, and you want to give an antipsychotic, you can make Parkinson worse because you are giving a dopamine blocker in a patient who has already low dopamine. So that's why the only drug that normally we can give, if we really need to do it, that's quetiapine. So you can give quetiapine in a Parkinson patient who shows some psychotic behavior. Okay. So I was talking about what medication can be given in a dementia patient. So it's not common that we give medication for dementia patient, but there is a group of medication which is cholinesterase inhibitor like donepezil, galantamine, memantine, reverse mind, this can delay the progression of dementia to a modest extent. Okay, so let me just show you one thing because that comes in exam. So far, all good, guys. You are understanding the dementia part. Okay. So if we suspect that patient has got Alzheimer's disease, then yes, you can give them this medication. So cholinesterase inhibitor, it can increase the cortical cholinergic function, and it is typically used in mild to moderate Alzheimer's disease. So in mild to moderate Alzheimer's, you can use any of these cholinesterase inhibitor, so donepezil, rivastigmine, galantamine. How about memantine? So memantine is another group of medication which we normally give in severe disease. Can anyone tell me which one, memantine or this cholinesterase inhibitor, which is safer in someone who has got cardiac condition? Memantine, so that's most of you. Yes, so most of the time we go for memantine. So if now both of these, cholinesterase, memantine, it can cause trouble. But true that yes, we can use memantine for these patients, especially if they have got a cardiac issue. But sometimes memantine can also cause a trouble. Next, if a Alzheimer disease patient or a dementia patient develops depression, can you give antidepressant? Yes, you can. What is the best antidepressant for that? Citalopram is usually the treatment of choice for a depression with dementia. Okay? How to prevent dementia? So we say that there are few strategies which can help to reduce the possibility of dementia. So healthy blood pressure is very important. Physical exercise, mentally stimulating activities, social activities which are fun and rewarding. Okay, so these are all better for dementia prevention. Benign senescent forgetfulness or age-related memory loss. So there is a condition called age-related memory loss in which it's not severe. Like you will not get like involution of their brain cell if you do a scan in this like age-related memory loss patient, which you will get in an Alzheimer patient. There will be atrophy of the brain cell. In age-related memory loss, which is common in patients who are quite elderly, like 70, 80-year-old. So for them, short-term forgetfulness, inability to find the right word, and also sometimes inability to find the items that they store away, forget to pay accounts. So it's just like very common thing, which is a part of normal aging. It doesn't come in exam because it can get quite confusing if they give it. Yeah, it's a senile dementia, same thing. Paraphrenia. Paraphrenia is called late onset schizophrenia. So if a patient develops paranoid psychosis, that means they're suspicious of everything for the first time in their life. So never been diagnosed with schizophrenia. For the first time in their life, they're having paranoid psychosis. Then you will call it paraphrenia. And yes, the treatment will be antipsychotic, so either risperidone or olanzapine. Okay, so that was all about dementia. Now moving on to delirium. So delirium, there is a lot of name for it. So it can be acute confusional state, can be acute brain syndrome, lots of name is there. But the main feature is sudden onset of confusion, disorientation, impaired attention, and it just takes over days to hours to happen all of this. So suddenly patient got disturbed, especially if they become very confused, lack of awareness of where they are, and then having attention deficit, then you can think it is delirium. Delirium patient can also have hallucination, delusion as well. But hallucination is quite common in patient with delirium. So they can get this perceptual disturbance, which is basically hallucination, disorientation, even memory impairment sometimes. So these patients are usually elderly and they can have this kind of fluctuation of their mental status. So when you are looking at the patient looks very confused. Suddenly after an hour, patient talking to you just normally. And then suddenly they have confusion. So fluctuation of their mental status is a very common finding in delirious patients. Okay? They can also get the psychotic symptoms because they're having hallucination, delusions. It can get worse at night. So if a patient you suspect that they can have delirium, the first thing that you need to rule out is that if they have got any infection anywhere. The most common infection in elderly which causes delirium is urinary tract infection. So always rule out UTI in a patient who is delirious. And also others like pneumonia, otitis media, any other infection can cause it. Sometimes some medication can cause it. Like anticholinergic medication sometimes can cause delirium as well. So how we treat a delirious patient? If a delirious patient is aggressive or violent, giving oral medication will not work. So violent, aggressive patient, you will need to give them IM haloperidol. So IM haloperidol, or you can also, so two things. If it is violent and aggressive, you need to calm them down. So to calm them, you can either use IM midazolam, or if the patient has IV line already there, then IV diazepam. You don't give diazepam as IM. So that's for violent, aggressive patient. If the patient is psychotic, that means having active hallucination, delusion, in that patient, you give IM haloperidol, or you can give IM olanzapine. But IM haloperidol is commonly given for a psychotic patient. Okay? So these are all about schizophrenia. We discussed schizophrenia in our first class, so you can go through them in your own time. So that's all about delirium, guys. Any question with dementia delirium? Okay, if you don't have any question, let's take a 10-minute break. And after that, we will start with some of the other cages. All right, everyone, let's start the class again. So Dr. Asfar, MMSC so you don't need to know how to do the construction and language. It's not important. They don't ask you how to test it. Pseudo dementia and its treatment. Pseudo dementia is a severe depression. So you need to treat the depression with antidepressant. Moving on to impulse control disorder. So impulse control disorder, we normally go through Kaplan step to psychi, chapter 32. So let's open that. So this is the chapter 12 in psychiatry, Kaplan step to psychi. So we're going to discuss the impulse control disorder from here. Okay. So you have got intermittent explosive disorder. In intermittent explosive disorder, a patient gets a sudden episode of failure to resist aggressive impulses, which causes serious assaultive acts or destruction of property. So the patient is actually not very angry, but there is a sudden outburst of anger which causes like a severe assault to someone or maybe some property. And the patient is unable to resist that aggressive impulse. So have a look on here. The police arrest a 24-year-old man after he beats up an older man, causing severe injury to his head and neck area, requiring more than 100 stitches. The 24-year-old man beats an older man. When asked why he assaulted the older man, he replies, he took my potato chips. So you understand that the degree of aggressive act is typically out of proportion to the stressor. So just because of very tiny stressor, the aggressiveness, violence can be way out of it. And it's not like always patient is aggressive like that. Suddenly patient has this kind of like explosion or anger outburst. It's common in men than women, especially men in prison or women in psychiatric facilities. So if you do the examination, everything will be normal in this patient, definitely. Treatment. Sometimes you can give them some mood stabilizers. So you can give them sodium valproate, which is like one of the mood stabilizers. So you can give them anticonvulsant, antipsychotics, sometimes even SSRI. So even you can send the patient for a psychological counseling. All of this can be tried, but none of these are like quite effective. Okay. Next, kleptomania. So these kind of conditions, they don't ask you the treatment in the exam. They give you a scenario and ask for the diagnosis. Kleptomania it's a disorder characterized by a recurrent failure to resist impulse to steal objects that the patient does not need. So you have heard about kleptomania patients a lot, I guess. So patient feels the urge to steal tiny little objects which patient doesn't even need. So if the patient does not steal, it causes intense anxiety. And when they steal, there will be release of anxiety. Okay? So 25-year-old woman has a history of more than 20 arrests for stealing a small item. She comes from a wealthy family. Her parents do not understand her behavior. At home, she has numerous salt and pepper shakers, napkin rings, ashtrays, none of which she needs. So you understand what is kleptomania? It says that kleptomania sometimes can be associated with obsessive compulsive disorder and eating disorders such as bulimia nervosa. In this patient, you'll need to send them for psychological counseling, so either insight-oriented therapy, and in this therapy, the psychologist actually let them understand their behavior. And sometimes you can also do this systemic desensitization, like the response prevention. Okay. Usually medication is not needed, but if you need to give it, then SSRI will be the first line. Pyromania. So pyromania, it's a condition characterized by deliberate fire setting on more than one occasion. So this is also an impulse. Patient gets this kind of sudden impulse to set something on fire. And if they don't do it, there will be intense anxiety and a release of anxiety once they do it. Sometimes even they get like gratification or satisfaction out of it. So that's pyromania. 19-year-old teen with mild intellectual disability is arrested after he is found setting the neighbor's garbage cans on fire. Neighbors had observed him in the past starting fires in his own backyard, staring at them for hours and watching them burn. So you can understand what is pyromania. More common in men, sometimes like men who has less IQ or mentally retarded. Remember, this patient will not have any remorse for the consequences of their actions. So they will not be sad or sorry for it. Sometimes they say that the patient can become sexually aroused by the fire also. There is no treatment for this. You might need to just incarcerate the patient. Gambling disorder. So gambling disorder nowadays, it is under DSM-5. It is not under impulse control disorder. It is under substance abuse disorder or addictive disorder. So gambling disorder means that a person who has persistent gambling behavior, which causes them to lose money, and they might try to attempt to stop the gambling, but they can't do it. So it's a psychiatric disorder where patient cannot stop the gambling. Okay. Common in men. The only treatment that's given is called Gamblers Anonymous. So you send the patient to a group of people who are also used to be gamblers, and then they share their feelings. And sometimes patient can also share their feelings, how they started their addiction. And then gradually with talking with the peers, sometimes patient can feel better and can get out of this situation. Trichotillomania. So trichotillomania, according to the new DSM-5, it is now no longer impulse control disorder. It is under OCD. So trichotillomania is a disorder where patient needs to pull their hair, causing hair loss. And if they don't pull their hair, it causes intense anxiety. So a 20-year-old woman is rushed to the hospital after she complains of severe abdominal pain. She is thin and withdrawn, missing a lot of hair from her scalp. Physical examination shows intestinal obstruction. That's usually called trichobezoar, which means that because patient is like pulling out hair and then sometimes they're also taking it in. So long-term taking of hair, it can cause intestinal blockage or obstruction. It is common in patient who has other condition like OCD, depression, all of those. So hair loss is significant all over the body, mostly scalp, may eat the hair, causing the obstruction. And if you examine their scalp, you will get short, broken hair with long hair. Now, this is important. There are some conditions where patient can get loss of hair as well. Like patient can get fungal infection, okay, like a tinea capitis, and the fungal infection on the scalp can cause loss of hair. Fungal infection will have a scale and kind of like a ringworm-like feature. And there will be uniform loss of hair. But in trichotillomania, because they are pulling out their hair, there will be some hair will be long, some will be short. So there will be different sizes of hair. Okay, so that's how we know it is trichotillomania. Treatment is basically sending them to a psychologist for behavior modification And sometimes if it is really bad, you can try any of these SSRI, anticonvulsant, antipsychiatric. Okay. So that's all about impulse control disorder. Any question? Yes, Gamblers Anonymous is available in Australia. Okay, moving on to our next topic, eating disorder. Eating disorder is super, super important. So questions come from here a lot. So there is a new guideline nowadays that we want you guys to follow, which is this 2017 guideline. So that's the main guideline that you should follow for eating disorder. But there is also one guideline which I will open up later on, but let's go with this one first. So eating disorder means that patient has difficulty to have like appropriate nutrition and food intake. And these patients can be complicated with life-threatening complication, both medical and psychological. So early detection is important. So the new guideline has said a lot of other subtypes of eating disorder, but the main two is anorexia nervosa and bulimia nervosa. So these two is the main one that you need to differentiate. So anorexia nervosa, the guideline is patient will have an abnormal perception about their body image. So disturbance in body image. So even though patient is not like overweight, they will think themselves overweight and they will need to reduce their weight by any means. So abnormal perception of body image, that's the first thing. Intense fear of weight gain. So because they have this disturbance in their body image, they have intense fear to gain weight. So they will do behavior which will interfere with weight gain. So that's the second. So first, disturbance in body image, intense fear of weight gain, and so that they don't gain weight, they will do restriction of energy intake, resulting in a significantly low body weight. So remember, this is how we differentiate. If we are not sure, then we look at the BMI of the patient. If the BMI is less than 18, then it is likely to be anorexia. BMI more than 18, most likely it is bulimia. Okay, so that's one of the very important clue in the exam. But anorexia nervosa, the main finding you should remember that they have abnormal perception of their body image. They feel they are overweight. So they have this intense fear of gaining weight. And that's why they do some restrictive behavior. Now, restrictive behavior, one, that they can do starvation and very restricted diet. Then the other type could be like they can vomit. So they, even if sometimes if they eat a little bit more, they will just vomit it out. So induction of vomiting. So just because patient is vomiting it out doesn't mean that it is always bulimia. It can be anorexia as well. Anorexia patient also sometimes they involves themselves with excessive exercise to lose weight. So any kind of way to lose weight they can do. So either induction of vomiting, restricted diet, starvation, okay, and sometimes even purging or vomiting. So what is bulimia nervosa then? Bulimia nervosa, patient will also have this abnormal image about their body, but sometimes they will lose control over their eating and then they will do binge eating. So after eating excessive amount, they will feel very guilty. Now to alleviate that guilt, they will do some inappropriate compensatory behavior. so that they don't gain weight. So they will do induction of vomiting. They can sometimes use laxatives, diuretics, even excessive exercise or fasting. But mostly they do vomit. Okay? So that's how we say bulimia nervosa. First binge eating, then doing some compensatory behavior. But this patient, because they do binge eat, they don't lose significant weight like anorexia nervosa. That's why their BMI usually are good. What is this binge eating disorder? Binge eating disorder is a recurrent episodes of binge eating where patient cannot stop it, okay? And then they get very distressed about it, but then they don't do any compensatory behavior like bulimia nervosa. So they just have these episodes of binge eating, that's it. So that's binge eating disorder. Other disorders that they have given in here, these are not important to know. So they have written in here, there are a few signs of eating disorder which you can go through. These are some of the investigations that we do in a patient who we suspect to have eating disorder. So sometimes the question asks that which of the following is not an investigation for eating disorder patient. So remember, we check their full blood count, liver kidney functions, glucose, urine. We also check their all the vitamins and mineral levels, ECG. We can check the hormone, X-ray, especially if they have delayed growth, and bone scan or bone densiometry if someone has got 12 months of the disease or amenorrhea. Remember, sometimes anorexia nervosa patient can also have irregular menstruation or sometimes even total absence of menstruation. Okay, that's one of the finding as well. So these are your main laboratory laboratory investigations that you would do. What is the management? So management depends on how bad it is. There are some criteria that are you going to admit the patient in a psychiatric unit or in a medical unit? So remember a few of these. It doesn't come in exam because it is quite a difficult thing to remember, but give a good read that what are the main criteria to admit this patient in the medical unit. But the treatment in these patients, what we do, so that's what I'm going to discuss with you. So this was that other guideline, which is now it's an old guideline, but still it has some important information. So remember in DSM-4, which was the previous guideline, they kept amenorrhea as one of the criteria to diagnose anorexia nervosa. But in DSM-5, they have removed this. So nowadays, amenorrhea is not needed to diagnose anorexia nervosa. So this is important. So what are the physical examination finding that you can get in anorexia and bulimia nervosa? In anorexia nervosa, you can get growth delay. You can get very cachectic, thin patient, dry, thin hair, sometimes even lanugo hair, full peripheries. You can get bradycardia. You can get postural tachycardia, postural hypotension, decreased muscle bulk, but the most important which comes in exam is ankle edema because of malnutrition. But in case of bulimia nervosa, because they do a lot of induction of vomiting, they can get dental erosion and parotid gland enlargement. Okay. So that's the finding in eating disorder. This comes in exam a lot, so please try to remember. Ankle edema for anorexia nervosa, for bulimia nervosa, dental erosion and parotid gland enlargement. Also remember, bradycardia is common in anorexia tachycardia common in bulimia. And we discussed about what are the investigations we are supposed to do in a patient who we suspect eating disorder. Treatment. So both of these eating disorder, anorexia and bulimia, your initial treatment should be psychological counseling. But there is a specific psychological counseling that is better for anorexia nervosa. So they say that the strongest evidence for anorexia nervosa psychological treatment is family-based therapy. So you involve the parent to get actively involved in helping this patient. So especially if it is a young patient, then family-based therapy is very good idea for anorexia nervosa. What about bulimia nervosa? For bulimia nervosa, the strongest evidence of psychological counseling is CBT, which is cognitive behavioral therapy. So you can see that what are the findings you can get in an eating disorder patient. Like you can get leukopenia, thrombocytopenia, anemia, you can get hypocalcemia, you can get hyponatremia, metabolic alkalosis. So these findings also comes in exam. So please make sure you go through this. If you can't open up by this link, just write eating disorder, RSCGP, and then find out the 2011 guideline. Okay, any question guys with the eating disorder? Now, substance abuse disorder, I normally don't discuss this in the class because it's all about just reading. So you need to read the chapter 12 from John Murtagh just to go through some of the substance abuse. And I'll show you from RSCGP guideline what's the important one. So there's a lot of substance abuse disorder, and you need to know like some of the symptoms and the risk of substance abuse. Okay, first of all, so amphetamines, cocaine or MDMA, so these are sympathomimetic drugs, which means it can increase the sympathetic nerve. So patients who has like excessive amount of this sympathomimetic, they can get CNS excitation, so euphoric, hallucination, agitation. They can get hyperreflexia, tremor, hyperthermia, flushing, and most importantly, you can get a dilated pupil. Cardiovascular, tachycardia, hypertension, GIT, nausea, vomiting, diarrhea. So you can see all the like sympathomimetic findings will be there in this illicit. The main complication that can happen with this is that patient can end up getting an acute coronary syndrome, seizure or epilepsy. They can get hyponatremia from MDMA or sometimes even serotonin toxicity. Okay. Then there are some treatment options also written in here. You can go through that in your own time. So you have understood now that for sympathomimetic, which is MDMA, and you have got cocaine and amphetamines, this usually gives a similar kind of symptom or toxicity. How about opioids? So opiates mainly causes depression. It's not excited, like it doesn't stimulate. So it causes depression. So CNS depression like drowsiness, respiratory depression. So everything can get slow in this patient. The risk is respiratory failure, then sometimes rhabdomyolysis, pulmonary edema, all of this can happen. In an opioid toxicity patient, naloxone IV will be your treatment of choice. How about cannabis? Cannabis causes mainly like depersonalization, disorientation. It can cause memory impairment. Patient can get psychotic. Okay, so psychosis is one of the complications with cannabis. So in here, they have written each and every drugs, what usually they do. You should go through that just at least once. They ask, like sometimes they give you a scenario with some of the features that I have discussed, and then they ask what is the most likely drug this person might have taken. So you'll need to know from the history. Okay, now let's just go through quickly from John Murtagh 8th edition, chapter 12. Just 1 second, let me open it up. So drug and alcohol problem is in chapter 12. It's a very boring chapter, and I'm sure you will also feel the same, but you need to read it at least once. Okay, I'll go through very quickly what you guys should not miss from here. So smoking. So you will go through this thing just a little bit, that everyone knows what smoking does, but still you need to go through this thing. So let's see. So anyone who you are going to counsel about smoking cessation, you need to follow this 5A framework. 5A include ask, assess, advise, assist, and arrange follow-up. So these are the 5A that you need to follow. Then definitely if someone stops smoking, they can get withdrawal symptoms. So mainly irritability, anxiety, they can get restless. So most importantly, how you can help a patient who wants to who wants to try a smoking cessation. That's the important question. And another thing is that what is the most important question that will lead you to think that this patient is a highly addictive predicate, like highly addictive to smoking or nicotine? If a patient needs to smoke first thing in the morning, that's one of the important things. Okay. Now, if you are going to help a patient to stop smoking, you have to ask the patient to go for like complete stopping. It's not like just reducing the amount of cigarettes. They have to stop like totally. So they should just find out that, well, in the next 2 weeks time, I'm going to stop smoking. And then during that time, you can help them by giving some nicotine replacement. So you have got nicotine replacement therapy, which has lot of form. So you can give it by chewing gum, inhaler, spray, lozenge, lots of things are available, but none of them should not be used more than 3 months. So nicotine replacement therapy should be given to smokers with moderate to high nicotine dependency. And high dependency means that when they take more than 10 cigarettes a day. So you don't need to know any of this, like how the nicotine comes. So you just know that nicotine replacement therapy is usually one of the options. What are the other options for a smoking cessation? You can give them bupropion or Zyban. So this has similar effect to nicotine replacement therapy, but adverse effect can be insomnia, dry mouth, and most importantly, it can increase the risk of having a seizure. So you can't give bupropion in a patient who has known epilepsy. So that's another option, that's a medication. And then you have got Champix or varenicline, which is very commonly used in Australia. So that can be also given in this patient. And also sometimes nortriptyline can be given. Remember, vaping is not an alternative to smoking. Then alcohol counseling. For alcohol counseling, there is an important questionnaires that we ask called case questionnaires. Two or more positive case questionnaires suggest patient is a problem drinker. So go through that. But the most important thing, or out of these four questions, the one question which gives us an idea that this is a severe problematic drinker is if a patient needs to drink first thing in the morning to steady their nerve. Okay. So it's a lot of investigation we can do in a chronic alcoholic patient. You can go through them. So what is the standard drink? So it's not like you need to ask the patient to stop drinking. It's not like that in like smoking. The standard drink at the moment is that patient can have 10 standard drink in a week. Okay. And every like different kind of alcohol has different kind of measurement. So when patient drinks, they actually know how much they are drinking. So you need to advise the patient. If a patient is drinking more than 10, they need to cut it down. So in a week, they can have 10 standard drink. That's it. So there is a 6-step management plan for helping a patient to reduce their alcohol intake. So you can just read these things. Now, according to JAM, it says that for men, the safe limit is fewer than 12 standard drink per week. And for female, fewer than 8 per week. Okay. But the RSEGP says 10 standard drink. So they change this like every few years. They increase the standard drink. I don't know why, but according to JAM, for men, less than 12 in a week. For women, less than 8 in a week. Okay? And definitely, they can get withdrawal symptoms if they stop drinking or they reduce drinking. But the main one is delirium tremens. So delirium tremens is a severe form of alcohol withdrawal. So first of all, let's say if a patient who is like trying to reduce their drinking, if they get withdrawal symptom, what you can do, you can give them diazepam, which might help with their sudden withdrawal symptom. You can also give them thiamine. But in a patient who has severe alcohol withdrawal causing delirium tremens, that patient needs to be hospitalized. So patient will come to you that most of the time they just totally stop drinking. Then 3 to 4 days after that, patient start to get disoriented, marked tremor, visual hallucination, sweaty, tachycardic, having high fever, and severe sign of dehydration. So when a patient with delirium tremens means, you can understand by the name, they will become delirious, they will have tremor. So hospitalization, because they can be dehydrated, you have to start them with IV fluid, correct their electrolyte imbalance, start them with thiamine and diazepam. Okay, so this is the step-by-step management. So then there is illicit drugs. So you can go through this gem. So there is a table. So this is the table that I would like all of you guys to go through. So they have also written what amphetamines, ecstasy. So all of these they have written. You need to just know the common symptoms that these patients can get and what are the danger or complication can happen. Okay. The important ones are amphetamines, MDMA, then cannabis or marijuana, petrol sniffing, LSD, heroin, cocaine, definitely. Okay, so mostly all of them, but few things like barbiturates, those you can rule out. Okay, so they also talked about opioid dependence. So For patients who are dependent on opioids, such as oxycodone, morphine, codeine, for these patients, it is a tricky thing that how you can help them to get rid of this dependency or addiction. So if a patient gets opioid withdrawal, we say that buprenorphine controlled withdrawal is used to prevent the emergence of a withdrawal syndrome. So if a patient is taking opioid for a long time, then you can try buprenorphine, single daily dose, increasing to 12 milligram on day 3 and then gradually decrease it. So we say that you just give them buprenorphine and just during the time when they can get a severe withdrawal effect and then gradually reduce it again. So that's for immediate withdrawal, buprenorphine. But to make sure that they don't go back to their opioids, you can do a maintenance program. Currently, there are 3 programs that we follow. One is methadone program, then there is buprenorphine and naltrexone program. So methadone program is another thing. So you can give them methadone and gradually wean the patient off. You can give them buprenorphine and also naltrexone. You don't need to go through like how many doses or anything. Just remember the name of this, that we try this medication for the patient to get out of the opioids. That's it. So that's mainly that you need to read for the illicit drugs. The only thing that we are now left with is childhood psychiatric disorder. Very important. So do you guys have any questions so far? For exact values, do we need to follow RACGP? I usually follow RACGP guideline. That's better. Okay, moving on to childhood psychiatric disorder, which we did not discuss in our pediatric class. It's a super important topic because a lot of questions come from autism spectrum, Asperger syndrome, lots of questions, ADHD. So autism spectrum disorder, it is a group of disorder characterized by problem with social interaction, behavior, and language. So there are genetic tendencies to develop this condition. Male is more likely to get autism than female. Diagnosis usually can be done before the age of 3. So what are the main findings to diagnose a child with autism spectrum disorder? So the main finding, number 1, that they have lack of communication ability. So they will not have like absent or bizarre use of speech. So there will be lack of speech. That's the main thing. That's why we say that if a child did not say any word by the age of, ideally by the age of 18, then there is a very bad sign, right? So red flags are there. Then social interaction problem. So if a patient has lack of peer relationship, like patient does not play with other children, or the child does not like to interact with anyone, so lack of social relationship. Then behavioral symptom. So these children are preoccupied with repetitive activities, and they are quite adhere to some repetitive purposeless ritual. What does it mean? That children who might have ASD, they will have a very strict routine. Any change in their routine can make them really angry and frustrated. So they have a rigid routine that they like to follow. They have a specific interest. That's the only thing they are interested about. And they keep on doing them repetitively. And they have this rigid adherence to rituals. Okay. So this is the main finding. So lack of social interaction, communication problem, and behavioral problem. Okay, so there are lots of type of autism spectrum disorders. So there is grade 1, 2, 3, 4. Lots of things are there which you don't need to know. One of the type of autism spectrum disorder is Asperger. In Asperger syndrome, patient has all of this problem, but it's not severe enough. So Asperger syndrome, they have speech, they can talk, but they have a bit of like an unusual kind of way of talking. They don't understand non-verbal social cues. They don't understand sarcasm. So they can communicate, but they have a odd communication pattern. Okay. They also has difficulty to interact with others, but it's not like they don't have friends. They will have friends, but it's a bit difficult for them. Behavioral, they also have a particular interest to something really specific, and they can be very, very good with that particular thing. So they are not having intellectual disability, but intellectual disability is common in ASD children. But for Asperger, sometimes they have a very high IQ, but the symptoms are there, but it's less severe than ASD. Okay, so that's how we differentiate autism spectrum and your Asperger syndrome. Next, attention deficit hyperactivity disorder, which is ADHD, very common in Australia. So, as the name says, patient has deficit in their attention and very hyperactive. So patient with ADHD, they are mainly characterized by inattention, hyperactive, and quite impulsive. Symptom will last for more than 6 months, and to diagnose a child with ADHD, this symptom has to be at least in 2 settings. It's not like parents will just say that my child is very active and impulsive, and we will diagnose the child with ADHD. If parents and school teacher both say the same thing, then only you can diagnose. Okay, so symptoms has to be present in multiple settings. So usually first recognized when child enters school. So usually you get some kind of report from the teacher that the child is quite hyperactive, short attention span, constant fidgeting, inability to sit for a few minutes, very loud and talkative, disobedient, sometimes fights with children, okay? And sometimes also will have like failure to stay quiet or stay still in the class, inability to wait in lines, and they can be also having difficulty with their homework because of lack of attention. Okay? Now, treatment. There is no investigation that can confirm ADHD, but there are some score that we do to diagnose this. Once it is diagnosed, the treatment is medication. It's not psychological treatment. You can send the patient or you can send the child or involve a psychologist as an adjunctive treatment, but the main treatment of ADHD is medication. Okay? And it has to be tried initially. It's not like you will start with psychologist first and then try the medication. It's the other way. Okay? So the treatment of choice is stimulant medication such as methylphenidate and dextroamphetamine. Okay? Conduct disorder. Now, I would like you guys to read a little bit more about ADHD because lots of questions come in the exam from ADHD medication and side effect. So give it a read from some of the Australian guideline about these stimulants that we use. So what are the common side effects? Like many patients with stimulant, they have trouble with like getting like less hungry, sleep problems. So lots of side effects are there and there are ways to decrease those side effects. So go through some of the guideline and read it. It's important. It comes in exam. And if you have any difficulty, just ask me in the class. I will discuss that. Okay, now conduct disorder. Conduct disorder is it's a precursor of antisocial disorder, you can say in that way. So children who has conduct disorder, they show this persistent violence for at least 6 months. So what they do is they will be bullying, fighting with other children, but most importantly, they will show some violence or aggression to others. So cruelty to animal or people, rape, vandalism, fire setting. So that means they are quite destructive and antisocial. You can't diagnose a child with antisocial. That's why you're diagnosing as conduct disorder. But once this conduct disorder child becomes 18, usually the diagnosis becomes antisocial. So what you can do is that this is the time you can actually help the child to get better. So having a healthy group and role models are a very good idea, so that the child does not like mix up with children who can make it worse. So role model, healthy group identification is usually the main treatment. So conduct disorder, just remember they are violent, aggressive, destroy property. That's it. What is oppositional defiant disorder, ODD? Oppositional defiant disorder means that the children who has hostile, disobedient, and defiant behavior towards some authoritative figure. Okay? So like if a child is quite disobedient towards the parent, towards their teacher who has authority, that becomes ODD. Okay? Fighting with the peers or fighting with a friend is not ODD. Okay? So ODD children, they can have other disorder like conduct disorder, ADHD, those things are common. So parents should be advised to spend time interacting with a child. So there is nothing you can do about it, but all you can do is like doing some family-based therapy. That will be the main treatment. Next, childhood enuresis. This is also quite important for exam. There is a RCH guideline about this. Please make sure you read it. So according to RCH, by the age of 6, children should be toilet trained. That means they should not wet bed at night. But even after the age of 6, if a child continues to wet the bed, that's what we call as childhood enuresis. Okay? So most of the time we say that first thing that we should rule out in a enuresis children is that if they have got a urinary infection. So if they ask for an investigation in the exam, we don't need to do it all the time, but you can do a urinary MCS to rule out any infection. So what is the main treatment for childhood enuresis? The main treatment is alarm therapy. So alarm therapy means that whenever child will wet the bed, there will be vibration in the bed, and at some point child will learn that they can't wet the bed, because if they wet the bed, their sleep will be broken and they will get the vibration. So it is a way of the brain to stop them to wet the bed so that they don't get any broken sleep. It can take at least 3 months for them to get better with alarm therapy. But that is the first line treatment according to RCH. Now, sometimes you might need to have something which can act faster, like a child going for a camp over, like a camping or sleep over. If a child going for a camping, alarm therapy will not work because it takes time. So for that situation, you can try desmopressin. And desmopressin can be a very good medication for a short-term relief of this bedwetting. Okay? Clear, everyone? But there's a bit of more discussion about this enuresis in RCH guideline. Tourette disorder. So Tourette disorder also important. It is an autosomal dominant condition in some cases. There are association between ADHD and OCD for patient who are diagnosed with Tourette. So what is Tourette? Tourette disorder means that if a patient or if a child has got both motor and vocal tics for at least 6 months. So motor tics means that kind of a abnormal movement. So child can have abnormal twitching of their face. They can have like constant pacing, spinning. So that's motor tics, like a abnormal involuntary movement. What is vocal tics? So constant throat clearing, constant like incomprehensible sound or making sound. So those are called vocal tics. So to diagnose a child with Tourette disorder, you need both vocal and motor tics for at least 6 months. What if only motor tic is there, no vocal tic? Then the diagnosis will become motor tic disorder. So treatment that we can do for children who has this tic disorder or Tourette disorder, you can try antipsychotic drugs like haloperidol, olanzapine, risperidone. Sometimes even clonidine can be tried, which is commonly used for this condition, but you can use any of these. So that's all about childhood psychiatric disorder. Now remember one thing, all of this I have discussed, it comes in exam. So please make sure you go through them. You don't need to know apart from what I have discussed, but just for enuresis, read a little bit from RCH. That's it. And I might share some ADHD medication side effect guideline with you. Okay, so we'll share something. I might just add it in the notes so that you can go through it. Okay. So that brings us to the finishing of our psychiatry class. Is it very difficult? It should be interesting now that you know what you need to learn. And I'm hoping that you have a very good basic at the moment. So oppositional, they will be only defiant and disobedient to the authoritative figure like teacher, parents, whereas conduct disorder, they are more destructive towards anyone, towards their peers, towards animal. So they are just cruel. Okay, they have more destruction. They are not just disobedient, but they causes violence and aggression. So please make sure you go through all of this that we have discussed. If there is any questions, any concern about any topic that you don't understand, ask me in the next class. Okay. For this one, Dr. Fatima, let's see what's this one. So a nurse working in a hospice has been ignoring an elder. Oh, this one. So yeah, they said answer as D, right? So the nurse is projecting her wishes by stating that the patient wants to be left alone, when in reality it is she who wants to be left alone. Now, I still feel like this is supposed to be rationalization because she's making excuses because like she's ignoring the elderly patient. So she's excusing by saying that she wants to be left alone. So in my aspect, it goes more with the rationalization than projection. Okay. All right, everyone, that will be for today. Thank you all for active participation. We'll be finishing it here tonight. Thanks, everyone. Have a good night.